Well, good afternoon, everybody, and welcome to today's webinar, Lessons Learned from the 2023 EQA Scheme for Molecular Testing of Lung Cancer Tissue Samples. My name's Simon Patton from EMQN, and I'm going to be presenting the data from this EQA scheme. Next slide, please. Just a few the normal housekeeping rules. I'm sure you're very familiar with them, but we've automatically muted your microphone to avoid any background noise. We are recording this webinar, so we are aware, I mean, there were just close to 200 registrations today, so many people will want to be able to watch it at a later date. So we will let you know when it's available, and it will be available through the EMKN YouTube channel. And most importantly, this is supposed to be an interactive session. So if you have any questions for me, please do use the Q&A function on your browser to ask questions, submit them to me. We've got a few minutes at the end of the webinar dedicated to the Q&A session. Okay, next slide, please. Your feedback helps us ensure that we provide good, robust, strong, educationally important webinars to you. So please do complete the feedback survey that you'll get via email shortly after the webinar is concluded. Takes no more than 2 minutes of your time. We do review that, and as I say, it's part of our improvement process. We do listen to what you say, and hopefully we provide you with good quality educational webinars as a consequence. Next slide, please. I don't think I need too much introduction, so I'm not going to spend any significant time on this. But for those of you who don't know, I've been working for EMKN for 25, 26 years, and pretty much since EMKN started. I've got a background in molecular diagnostics. I was trained as a marine biologist, believe it or not, but I've worked in human genetics for the last 25, 26 plus years. Most of that based in EMKN in Manchester, which we were originally part of the NHS. And then during COVID, the hospital span us out as an independent business. So EMQN has been operating on its own as a standalone community interest company, so a social enterprise type model or non-profit making organization since July 2021. Next slide, please. Next slide, please. My disclaimer and disclosures. Next slide, please. Right, over to overview. So I'm going to just give you a couple of slides really running through the principles of what we've been trying to do, why we're trying to do it, and what we've been doing in terms of delivering the EQA scheme here. So I'm sure many of you already be familiar with the principles of EQA, but it's worth reiterating them just to ensure that we've got consistency there. So the key parts of EQA is it's an external audit of your laboratory's performance, and it's part of the regulatory framework. But the main principles of what we're trying to do is to ensure that every laboratory gets the same sample for the EQA process. So we send the same material, shall I say, to each laboratory that participates. The laboratory tests that sample using their normal testing approach. We're sending a clinical referral. In other words, we're asking a clinical question and expecting a clinical answer from the laboratories. So our EQA schemes are fully interpretive. So we expect back from the laboratories a clinical report describing what the impact of that test was on the patient themselves. We then do the assessment of those reports. So we're, from a laboratory perspective, we're expecting every laboratory to treat that sample as a patient sample. So that's testing the sample using the routine, regular processes and the regular personnel that will be doing the real clinical samples for that test. And the aim is to really to benchmark your performance against all the other laboratories doing the same test. So the advantages for you from that perspective are you get an external assessment or measurement of the quality of your service. You're benchmarked against everybody else doing the same test. But more importantly, our emphasis is strongly favoured towards education. So all of our EQAs have a very strong educational component and training component. We feed back comprehensive and detailed feedback to every laboratory, individually to each laboratory, with a very thorough and comprehensive report that summarises the outcomes of the scheme and looks at the process and the errors we find and the key learning from it, and allows you to then see where you sit within the other cohort of the laboratories taking part. But there's no doubt there is still a regulatory component to it. So we are involved in the regulatory framework from a performance monitoring perspective. And in many countries, the regulators do take note of your performance in EQA, and it can suspend the activity of a laboratory if they feel laboratories performing poorly on multiple occasions, so what we would call a persistent poor performer. But it's also worth reiterating that everybody performs poorly. So no laboratory is perfect. Everyone can make mistakes. We're all human. And so we're not really after penalising laboratories that make individual mistakes, but what we're looking for is the laboratories are making systematic mistakes over time. Next slide, please. So our lung tissue EQA scheme is the largest EQA scheme for lung cancer tissue testing in the world. We had 447 laboratories participating this year, just shy of our highest number, which is 450. It's the 13th year we've organised this EQA scheme, and access to it was unrestricted and supported by sponsorship from a number of different pharma organisations listed on the slide. As a laboratory, you get 8 to 10 weeks to test the samples. And this year, the scope of the EQA included EGFR, BRAF, KRAS, ERB or HER2, and MET genes. So every lab is expected to test at least a subset of those genes and report their findings. And it's important when we come to our assessment process, I want to emphasize that the assessment process is not only robust and thorough, but also independent. So a team of expert assessors, and we'll show some data shortly about the numbers, a team of expert assessors will have assessed every single report. So this year, there were 2 samples that included full clinical interpretation. So there were 900 reports to assess in the context of full clinical interpretation. Every report was read by at least 2 expert assessors. And the remaining samples, close to 4,500 samples, were assessed as well independently by these peer assessors. So your reports have been read by at least 2 independent assessment team members, and in most cases, considerably more than 2. Next slide, please. So the aim of our EQA is to provide samples for you to test. We use a variety of different sample types. Predominantly this year, a mix of artificial FFPE materials that were designed to mimic a real clinical sample with variants of clinical interest in specific genes, which we just described in the previous slide. You were required to interpret those results in the context of the clinical referral we provided in a clear and concise manner. So the clinical question is what we're asking here. We do expect laboratories to be able to implement and use standardized nomenclature for all the reasons I'm sure we're aware of: consistency, harmonization, commutability of the end result, and to provide an accurate interpretation of the result to the patient, including a report that's accurate with respect to patient information, sample identifiers, etc., but also clear and concise. Next slide, please. So the format for the scheme this year was slightly different to previous years. So in previous years, we've only really tested EGFR, KRAS, and BRAF. This year, we decided that we would expand the scope of the scheme to include other and new and emerging biomarkers that we know are being reasonably routinely tested. So we split the scheme into 2 sub-schemes. So we had a common biomarkers sub-scheme that laboratories were mandatorily required to test EGFR, KRAS, and BRAF, and then an optional new and emerging biomarkers scheme where the EGFR gene testing was mandatory, but HER2 or ERB2 and MET testing was optional. In all cases, both sub-schemes had included 5 samples. Those samples have been manufactured for us by Horizon Biosciences UK, derived from lymphoblastoid cell lines from cancer samples. We send scrolls, not slides, and the testing requirements for the different samples were different but consistent between the different sub-schemes. So in both sub-schemes, one case was a fully interpretive case where you got the clinical referral as well as the sample, and you were required to report the genotyping interpretation and report that appropriately. And for the other 4 remaining cases, we just required a genotype result only. All of our samples were independently validated prior to distribution to the laboratories. Again, we used a number of different approaches to that. We included a ddPCR and targeted NGS assays to cover the range of variants that we'd included in the scheme design. Next slide, please. From an assessments perspective, so I alluded to the fact that we've marked over 5,000 results, this data point or results this year from the laboratories participating. We had a team of 29 expert peer assessors from 12 different countries. And you can see that by numbers that the largest proportion were assessors from Italy and the UK. Next slide, please. So just breaking down the participation data. So on the left-hand side, you can see a graph that defines the number of participations by count per EQA scheme year since we started the EQA in 2011. The orange bars indicates new laboratories coming into the scheme, and the blue bar indicates existing laboratories that have participated at least once in those last 13 years. And over time, you can see the number of laboratory participations has increased substantially. And this number is primarily dictated to by a quota that we define with respect to the sponsorship from the commercial organisations that support the EQA. But the key take-home message here is that over 3/4 of the laboratories that participate, and certainly in the last 4 years, have participated, hard sometimes to get the words out, have participated at least once in the last 13 years. And by and large, most have participated nearly every year. So the number of repeat participations is high, which is fantastic because EQA should be a part of your routine processes. But every year we get a small number of laboratories who are new to the EQA coming in. We don't foresee that sort of split changing hugely, and it's good to see that we've got new laboratories coming in to learn from the process, but also the existing labs learning from what we've been doing previously. So when you split out the participation data by region, geographic region, for the common biomarkers and new and emerging biomarkers, the graph on the left has it combined, you can see there's not a huge amount of difference, and that's encouraging to see. And when you compare it to 2022's data, which of course was only for everything all lumped into one, again, there's no substantial changes in participation. The only significant change in participation is from China, where we had about 5% less laboratories participating this year compared to the previous year. Next slide, please. So what I'm going to do now is going to run through the two different sub-schemes and data associated with the cases and the end results from that. So we're going to start off with the common biomarker scheme, which was mandatory for all labs taking part in the tissue lung cancer tissue EQA scheme. Next slide, please. So the first thing to do is look at strategies. Now, remember, the EQA was very specific about which genes were mandatory. EGFR, KRAS, and BRAF were mandatory for participant laboratories. And it's great to see that 95% of laboratories tested all 3 genes. There are a small subset of laboratories that only test one or a subset of those 3 different genes. And this is maybe due to specific requirements within the local region. But I think it's encouraging to see that the guidance, the published guidance and the NCCN guidance is that at least these 3 genes should be tested, that the majority of labs taking part in the EQA are testing all 3 genes. It's difficult to justify why a laboratory would only be testing, for example, for EGFR now in the context of lung cancer tissue testing, when guidance clearly states that they should be doing more than that. But there are specific reasons why that might be the case. Next slide, please. So looking at case 1, which was the fully interpretive case, this was a lady who presented with a persistent cough and dyspnea, was COVID negative, had other risk factors associated with lung cancer. A thoracic CT scan had been done and suggested that she had a large malignancy with enlarged lymph nodes. A fine needle biopsy had been done and identified malignant cells. And a biopsy was being sent for molecular diagnostics to evaluate further treatment options for this individual. Now, we expected the laboratories to test that sample, and what we expected to find in terms of a genotype was they could detect no clinically significant variants within the regions that we had tested in all 3 of the genes. So in other words, this is a wild type scenario within the context of the genes we had specified within the referral. Next slide, please. Next slide, please. So looking at the genotyping results, so remember there were 427 laboratories took part in this scheme. There were 12 critical errors, so 2.92% of all the tests undertaken resulted in an error. And when you look at the incorrect results reported, you can see that they're all false positive results across the broad spectrum of across both EGFR and BRAF and KRAS. So all 3 genes are affected. And looking at the assays, the take-home message from here is there's no real consistent theme. There's no systematic errors involved in the assay failure rates. So although the number of errors seems high, the overall error rate of 2.92% is within bounds of what we would expect to see for most of our EQA schemes, somewhere in the region of 3%. So worrying, but not significantly worrying compared to other activities. Next slide, please. Next slide, please. Looking at the interpretation of the result, obviously it's not just about the genotype, it's also the interpretation and how you confer that to the referring clinician. There were 3 critical interpretation errors. So these laboratories that got the genotype wrong, but gave the wrong interpretation of the context of the result for the patient. So one laboratory stated that the patient would have an increased likelihood of benefiting from EGFR TKI therapy. But of course, they've got no no sensitizing mutations in there in the first place, clearly wrong. Another patient stated that the absence of a BRAF mutation would suggest that the patient would benefit from 2 different drug therapies. And finally, one laboratory stated that results increase the likelihood that the patient would attain clinical benefit from anti-EGFR monoclonal therapy, but failed to mention EGFR TKI therapies. Of course, the 2 are different. And again, they received a critical error as a consequence of that. I think what's interesting from this, from the interpretation perspective, is that only a small proportion of laboratories gave a complete interpretation with respect to all 3 genes tested. So most only provide an interpretation for EGFR. Now, there is therapy available for all 3 of those genes. So we would expect that within the context of the referral that the laboratory would comment on the availability of therapeutic options or a potential response to that patient based on the test they'd done, not just on one gene that they tested. And I think this is a common theme for these types of EQA scheme, where we see, and probably also as a reflection, clinical practice associated with that. Next slide, please. Looking at the other cases 2 to 5, which of course were genotyping only cases, so no clinical report required from the laboratories. We provided a range of different variants here across all 3 of the different genes, with sample 3 being another wild type sample. So we had a BRAF V600E variant in there, a KRAS G12C variant in there, and an EGFR exon 19 variant in there, all relevant to the context of lung cancer. Next slide, please. So when we look at the error rates associated with that, you can see again that the error rates are pretty low and within the region of what we saw for case 1, which is the full clinical referral. So for case 2, which is a BRAF variant, we identified 1 false positive result and 4 negative results. And another laboratory received a critical error because they'd used the wrong reference sequence and therefore reported the wrong variant as a consequence of that. In case 3, which was a full wild type sample, there were 2 critical errors, false positive results. Case 4, which was the KRAS G12C variant, no false 7 critical errors, 1.69% of the number of tests undertaken, no false positive results, 4 false negative results, and 3 results associated with the incorrect variant identified, but in the correct gene. So in other words, another KRAS variant associated in that test. Most likely, I would say probably a codon 13 or something similar. Finally, in case 5, which was the EGFR exon 19, there were a large number of critical errors, but still under 3% of the total number of tests undertaken. All of them were, barring one, were false negative results. And in the last case, there was an EGFR variant, a different EGFR variant reported as a variant of unknown significance. So again, the wrong clinical result, which would have impacted patient care as a consequence. Next slide, please. So when we look at those in a little bit more detail, and the key findings from those assessments were for case 2, which is the BRAF V600E, there's still a large number of laboratories using test methodology that has great difficulty in assigning the correct variant, the correct result for that test. So here is a real-time PCR assay that can't distinguish between those two V600E variants. They both give a V600E, but of course there's a big difference between the two variants themselves. So although they got the right result, they weren't really correctly identifying the right variant at the time. Case 4, which was the KRAS variant, again, it's a similar story for codon 12. So quite a few assays now are still unable to distinguish between the various codon 12 variants. And of course, therapeutic options are defined on one particular codon 12 variant, G12C. So in that case, the assessment team made a note, we've strongly recommend that participants consider implementing a testing strategy that identifies each individual variant. And that's really pertinent to the KRAS 12, codon 12 variant G12C. Finally, in case 5, which was the EGFR variant, the reason for this was the 11 laboratories, or 12 laboratories, I say, just couldn't identify the G12, the exon 19 variant, even though it's present at a variant allele frequency that should allow detection using a technology like NGS. 7.5%, which is well within the scope of what an NGS-based test should be able to detect, and certainly for many other tests, quite considerably lower than that. Next slide, please. So in overall summary, we had 447 registrations for this scheme. We had a number of withdrawals, 12 withdrawals, a further 15 laboratories that dropped out without informing the EQA provider. So those 15 laboratories will get poor performance because they failed to let us know in advance. That left us 420 laboratories. I mean, the key take-home message here is do not get yourself into a situation where you don't submit results to us without letting us know. Not only will you get poor performance, but you're also depriving 15 laboratories potentially of participating in the EQA scheme. And in this scheme, we always have a waiting list. So there are always many more laboratories wanting to participate than can. So if you're in a situation where you know you're not going to be able to submit results, tell us in advance, please, to allow other laboratories potentially the option to participate. So looking at analytical performance, there were 39 critical errors made across the scheme, made by 30 laboratories. So 7% of the laboratories made at least one critical error. 22 laboratories made one critical error, 7 made 2, and 1 made 3. So that's 3 out of 5 samples were incorrect. So maybe some work to be done in those scenarios for those laboratories. Don't forget, in any one instance of critical error will lead to poor performance within this sub-scheme. So one error will still lead to poor performance. Looking at reporting performance, there were 3 critical errors made by 3 laboratories. So each one of them made a separate critical interpretation error. And looking at the data in more detail about where the laboratories came from in participation, you can see that China and Italy and Spain made up the largest proportion of laboratories participating in this sub-scheme. Next slide, please. So now onto the new and emerging biomarkers. So the second sub-scheme of the long tissue scheme. Next slide, please. So breaking down the strategies, remember the only mandatory gene to be tested in this sub-scheme was EGFR. So it's really encouraging to see that 84% of laboratories actually tested all 3 genes. And actually only 13% of laboratories tested EGFR only. So I take that as a very positive perspective. Again, guidance is pointing to much more than just EGFR testing in the context of lung cancer. This is a new and emerging biomarker, so it's deliberately designed to be bringing in more unusual variants or more challenging variants into the scenario. So seeing that 84% participated all 3 genes is fantastic to see. Next slide, please. So looking at case 1, the clinical referral case with the fully interpreted results. Again, a lady who had no history of smoking, CT scanner detected a shadow on her left lung. She had more than 20 multiple asymptomatic brain metastases detected via MRI. She'd had one round of platinum-based therapy. and had complete disease progression. She has further biopsies, and the question was being asked, will she benefit from a targeted therapy? So she a biopsy sample being tested, will she benefit from molecular therapy? Now, the expected result for this sample was an EGFR exon 20 deletion insertion variant with no variants in ERB2 or MET. Next slide, please. So the rationale for the case, this was a case specifically targeted at the question of how laboratories would treat an EGFR exon 20 variant. So we included it, so in the context of FDA licensing for this type of therapy, and we were really looking at how the laboratories would handle that scenario. These are quite challenging variants. There are multiple different variants within the same exon, but clearly there is now therapeutic options for patients to be tested, to be prescribed therapy that may target this group of variants within exon 20. Next slide, please. So encouragingly, there were very few genotyping errors, only 3, so 1.46% of all the samples tested. And across the different error types, there were 2 false negative results using 2 different tests, and there was also a sample swap in between 2 cases. So one laboratory reported the correct variant, but for case 2. So that was obviously the ERB2 or HER2 variant, and the assay is not relevant in this context because it was a procedural error rather than an actual test error. Next slide, please. So a little bit more detail about some of the themes we picked up from it. So several laboratories reported the variant incorrectly. So they reported it as an insertion, when in fact it's actually a duplication. So this is a common theme we pick up. And the use of the nomenclature guidelines very clearly dictates that the prioritization of how you name these variants. So in all cases, a duplication over an insertion. So if you need to read up a bit more about the details behind it, and I acknowledge the guidance is sometimes quite difficult to read, but the website displayed on the screen gives you quite a nice breakdown of how to interpret these types of variants themselves. Next slide, please. Looking at the clinical interpretation, there were 2 critical interpretation errors. So 1.03% of the samples tested. In one case, the laboratory stated that the patient was a candidate for a tyrosine kinase inhibitor instead of an EGFR exon 20 specific therapeutic option. And in the other case, there was a laboratory that classified the variant as a VUS, going on to state that the tumor was a positive for a clinically significant mutation. And again, not pointed to the fact that the patient would benefit, or was susceptible, shall I say, to an exon 20 specific inhibitor therapy. So in both cases, the patient would have got either the wrong treatment or, well, the wrong treatment as a consequence of it. Many participants also discussed the potential clinical benefits of a particular drug, and this is quite a nice example of why you should not be talking about specific drug names, but really referring to a class of drugs. We put this in to try and emphasize this point to you. So it's really important to get across to you that really, this example with this particular drug, which was actually withdrawn from the market in October 2023, you shouldn't be referring to a particular named drug. You should be referring to a class of drugs. A really nice example of why that's important. Next slide, please. Looking at cases 2 to 5, so just like in the other sub-scheme, all these cases were genotyping only, so we didn't require laboratories to provide a clinical report. And again, we tried to include a range of different variants, so that although there were no EGFR variants covered in case 1 only, we included 2 HER2 variants, and a MET variant as well. Although we didn't include a exon skipping, we did include an SMV. The rationale, again, these are all pretty standard referrals. These variants, were provided at variant allele frequencies that should be detectable by a large range of different technologies. So nothing lower in this case than 15% VAF. Next slide, please. So when we break down the errors that laboratories made in terms of detecting or not detecting these variants, we can see that in case 2, there were 10 critical genotyping errors, so nearly 5% of all the samples tested. Most of those were false negative results, 1 false positive, and two laboratories reported the variant associated with case 1. In other words, this is the sample swap. For case 3, there were 2 critical genotyping errors, both false positive results. So remember, that was a wild type sample. For case 4, there are 8 critical genotyping errors, so just under 4% of the samples tested. Most of them are false negative, but also there was an instance where a laboratory reported the correct variant, but in the wrong exon. And finally, case 5 genotyping errors, so just under 3%. All of them were false negative results. And I think case 5 was the MET variant. Next slide, please. So just looking in more detail at cases 2 and 5, because there were no consistent themes with it in the other cases. So in case 2, which was the HER2 variant, this is an example of the nomenclature issue we described in the previous couple of slides. So in this case, the laboratories incorrectly used the HGVS guidance to describe the variant as an insertion, when in fact it should have been a duplication. So I refer those laboratories to the HGVS guidance for prioritization of a duplication over an insertion. In case 5, which was the MET variant, there were 5 critical errors awarded, 4 for failing to report the MET variant, and 1 for the apparent transposition with a sample with case 3. The last nucleotide, also the important point here is the last nucleotide of MET exon 13 is either C3028 or C3082, depending on the transcript you use. So quite a few laboratories incorrectly described the variant according to the transcript they provided. So although they provided the right reference sequence, they provided the wrong transcript for the variant they'd actually called, and so they got mixed up between 3028 and 3082. So awareness there, particularly on this variant, and we have used this variant quite a few times for that very specific reason. Awareness of just making sure you're using the right transcript for the right reference sequence that you're using. Next slide, please. So in summary, for this scheme, there were 229 registrations, so about 2/3 of the number for the full scheme. There were 7 withdrawals, and another 9 laboratories didn't submit results without letting us know. So in total of 213 laboratories took part in this sub-scheme. So less than obviously in the common biomarkers, but I think still encouraging. It's still telling me that many laboratories have a much more expanded scope of testing than just the core genes around EGFR, KRAS, and BRAF. And when you look at the distribution of where the laboratories come from, the highest number was from China, Italy, and Spain, again replicating what we see in the common biomarkers EQA. Looking at analytical performance, so there were 28 critical genotyping errors made by 20 laboratories, so just under 10% of laboratories made at least 1 critical error. 14 of the laboratories made 1 error, 4 made 2, and 2 made 3 errors. Reporting performance, so as we previously described, there were 2 critical interpretation errors, each one of them made by a separate laboratory, so just under 1% of the laboratories taking part in the scheme. Next slide, please. So finally, sort of wrapping up with some summary data, so looking at the EQA performance data and the key learning points from the EQA. Next slide, please. So looking at the participation performance data, so on the left-hand side, you've got the participation data since 2014, so a rolling window, if you like, of 10 years worth of the EQA scheme. And what you need to understand here is the blue is the laboratories that submitted results. So these are labs that participated, registered to participate. So blue submitted results, purple didn't submit results. So these are the laboratories that would get poor performance because they haven't told the EQA provider. And the orange ones are the laboratories that withdrew from the EQA scheme. And you can see that from 2014 through to 2023, about 10% of laboratories annually don't submit a result. Either they withdraw or they just don't submit a result. So 90% of laboratories that participate send in results for assessment. So it's really encouraging to see that in 2023, that number has now significantly changed. So it's nearly half of what it was last year in 2022. About 5% of laboratories didn't submit a result for one reason or another. And when you look at that data for the two sub-schemes, you can see there's very little difference between the two sub-schemes. So it's consistent across both schemes, which is also really encouraging to see. Top right-hand side is the assessment scores. And so the blue bars define the genotyping scores. So remember, this is the mean score across all the cases we assessed. So remember, it's 5 cases, the mean score across 5 cases. And our marking strategy is based from 0 to 2. So if you get 2 marks, you've got everything completely correct, and your mean score is 2 for all 5 cases. Anything less means the laboratories are making small errors across at least one of the cases. And the encouraging thing here is we want to see the genotyping scores high, at least sort of 1.6, 1.7. And it's very clear from the data that the level of accuracy of testing is pretty consistent. We're not seeing huge changes over years. Not everybody's getting everything right, but the large majority of laboratories are getting the right result in the genotype. When you look at the interpretation, of course, that's much more subjective. It's only marked over a fewer number of cases, so 2 cases out of 10 rather than all 10 cases. And of course, the interpretation result is context specific as well. It's also location specific because the regulations in different countries mean that some things you can report and can't report. But also, we allow reporting in multiple languages. So there's an element of language embedded within the report, the scoring that we'll be providing to laboratories on feedback. But the overall theme here is that the mean score for interpretation is lower than genotyping. We would expect to see that, but it's still pretty high. So in other words, laboratories are generally doing a very good job of interpreting the results they get from their analytical testing process. Looking at the critical error rates, so these are errors that would result in a patient harm. So most likely incorrect prescription of a drug, or giving the patient a drug they shouldn't receive, or conversely not providing with a drug they should receive as a consequence of their test result. And you can see what's very common with all of our EQA schemes: new test technologies or new strategies involved often lead to very high critical error rates. So when we first launched the scheme in 2011, the error rate was nearly 11% of laboratories made a mistake. And now, over time, that error rate drops down. And now what we're seeing is an error rate of just under 3%, which is consistent for this scheme, and also consistent with nearly every other EQA scheme we run. So 3% or just below is the sort of mean score we would expect to see for critical error rates. So 97% of all laboratories are getting the right results or tests undertaken, and a very small number of laboratories are getting the wrong result. So it's lung cancer tissue testing is well established, and that's what you're seeing in the error rates. It's pretty robust, and the laboratories by and large are doing a very good job with the testing process. Next slide, please. So the key learning points from this year's EQA. First thing to say, we provided artificial reference materials this year. They performed really well in all laboratories. So the sample failure rate associated with them was exceptionally low. Only 2 out of 1,049 samples tested was a failure, so less than 0.2%. The standard of genotyping is exceptionally high, so less than 3% of genotyping errors, again, reflecting what I said previously. This is well established, the testing, and although we're looking at new and emerging biomarkers, by and large, most laboratories are not only doing a good job, but they're doing a good job on multiple different tests associated with it. Laboratories should, another learning point, laboratories really should include the results for all the genes they've tested and not omit the results for the genes where no variant is interpreted. So you should be reporting the full scope of the test you've undertaken and the implications for the patient. We're starting to see the introduction of RNA-seq used frequently in the test strategies from many laboratories. This is obviously a relatively new technology with clear benefits, particularly around fusion gene testing, but its successful use in the laboratory is dependent on a number of factors. So not only would expect, obviously, there's the gene got to express the variant in any tumor type, but the tumor content has a bearing on the quality of the result. The sample quality and the processing has a bearing on the end result. The RNA extraction process you use and the way you amplify the RNA has a bearing on the result, and the level of bioinformatics filtering also has a significant bearing on the end result. So the take-home message from this year's scheme was we thoroughly recommend labs do a full and complete verification of any RNA-seq assay performance against the DNA method used before it's used clinically. Next slide, please. A couple of other points from the genotyping nomenclature. So we recommend that laboratories that have missed clinically relevant variants due to the limitations of the test methodology they use, consider using other methods with higher sensitivities and broader scope. So it's undoubtedly true that when you look at the spread of strategies used by laboratories, and I didn't give you the detail here, there are across the 420 laboratories at PART, there's at least 100 different technologies used for doing this, for taking part in this EQA scheme, or tests, should I say, not technologies, but test strategies used. And many of those strategies are very targeted on a limited number of variants and have significant limitations. So if you start to consider the use of more sensitive test technologies with a broader scope of variants being tested, for an example, an NGS sequencing strategy, doesn't have to be NGS, but something that's not limited purely to very small and defined hotspots, then you will broaden the treatment options for patients. And the guidance out there from other best practice guidance is strongly recommending that you need to include a broader range of variants tested. So we'd encourage laboratories to consider the methodology they're using and whether that's really appropriate for the patient itself and whether it's giving the patient the best options as a consequence of it. Last thing to say is that we are an organization that's heavily promoting standardization of how you report the variants, so the nomenclature you use. We recognize that in the past, we very heavily promoted the use of LRGs over standard NCBI refseqs, etc., for the reasons that the transcript remains stable. The LRG project has been discontinued, and we've moved, and the community is moving forward to using the main initiative, but it is still in development, and we recognize it's not perfect and it's not fully up and running for every single gene. But where possible, we would strongly encourage laboratories to use main transcripts, either main select or main plus clinical. We will provide further guidance later on this year, but we've already provided a policy statement, if you like, on our feelings about how laboratories should be using reference sequences. Next slide, please. Looking at interpretation, so the standard of interpretation is also improving, and many laboratories include a pretty robust statement about the implications for the patient. We still think there's areas for improvement and what laboratories can be doing to get across the end result to the clinician. So a small minority of laboratories are still not providing sufficient details around how they've done the test, and particularly things like limited detection. Some are also confusing analytical sensitivity with limited detection as well. So if you look in the scheme report we provided this year, we give a bit more detail about what our expectations are associated with this. The main take-home message here, though, is that the clinical interpretation should be tailored to the patient you're testing. It's not really good enough just to provide generic background interpretive comments. The patient, you're getting a sample from a mock patient that's asking a very specific clinical question. You should be addressing that question. Regardless of the genotype you attained, we would expect to see an interpretation. So it's very easy to misread these generic comments, and there is a risk associated with that the patient could get inappropriate treatment. For example, a misleading comment about discussing resistance to a particular treatment type can be misread as a general comment when actually the actual result indicates a patient may have increased sensitivity to a particular therapeutic option. So make sure you tailor your result, your interpretation, to the context of the test you're actually you're undertaking. Next slide, please. So reporting. So finally, it's looking at we assess not just obviously the analytical process and how you interpret it, but also how you actually convey that information to the laboratory, to the end user. Again, consistent with the other key areas, that's really improving as well. So laboratories are doing a really good job of conveying the information to the end user. And although some reports might seem very basic, the key message is being conveyed on the front page of the report. We can provide, if you really want some more guidance, we can provide examples that you can use to help guide your report structuring. But I can't get across to you that how you structure that report has a big implication for what the clinician, the end user, can do with the data. In most cases, the clinician doesn't have hours to look through 30 pages of report to find the key take-home message of the results for the patient. They need to have it there in front of them, clearly, concisely laid out in a way they can get the information very quickly. There are still consistent mistakes we find, though. So if you're using multi-page reports, pagination is really important. It's not just pagination, it's page 1 of X. So which indicates how long the expected report would be. So just these little nuances make a big difference to the quality of the reporting process. Multi-page reports as well, having patient identifiers should be present on all copies of the page, so at least you're talking about the same patient. But a key thing we're finding is far fewer laboratories now use multi-page long reports. In the past, we would frequently find reports of 12+ pages. Nowadays, most laboratories are keeping it clear, concise, 1 to 2 pages, which is fantastic. So I think the quality of reporting is also massively improved than it was 11 or 12 years ago. Next slide, please. So last real slide, just a few timelines associated with the 2024 scheme. So we are running the tissue scheme again this year. And the samples will be going out, or if they haven't gone out now, they will just be going out. The results submission deadline is end of August, and the final results will be published in December. But just a reminder, we also run EQAs for lung cancer plasma testing, this time in conjunction with GenQA. Those samples go out slightly later in the year, and conversely, the results submission deadlines and reporting guidelines are slightly later. We will be doing a webinar at the end of this month, I think on the 27th, which summarizes the results from the 2023 lung cancer plasma scheme. So if you haven't already registered for that EQA's webinar, then our membership mailing list will be sending out a reminder sometime this week, I think it is. But the deadline, the date for that webinar is the 27th of June. I think it's 1300 BST as well. So same time as this started. Next slide, please. So lastly, just an acknowledgement. This is not my work. This is a work of a large team of people. So to the EMQN team, primarily Melanie and Arthur, who've done all the hard work in grafting to produce the reports, etc. But most importantly, to the huge team of 29 scheme organisers, assessors and scientific advisory group members who helped deliver the assessment process. We couldn't do it without them. They are fundamental to what we do, and it allows us to do a really thorough, in-depth assessment of your data. So don't forget, nearly 5,000 results were marked this year. So it's a very big job, and I'm very grateful to all those individuals who contributed to that process. Next slide, please. So lastly, we've got a few minutes left over for a Q&A. So if you have any questions, please do submit them via the Q&A. I don't think we've got any at the moment, so what we'll do is we'll hang around for a minute or so in case we've got some questions coming in. I've got a question here. Actually, someone submitted a question. So yes, okay. So the question here about do we detect any systematic errors with the same samples? And have we got examples? So participating in EQA is a fantastic way of detecting systematic errors. So although I haven't got an example for lung cancer testing, I can provide you with an example from hereditary breast and ovarian cancer testing, where we sent a sample that contained a large small indel. We're talking 62 base pairs in one of the BRCA genes. And in isolation, we found a 20% error rate associated with testing that particular indel. And when you look at the data, in isolation, every one of those labs that reported a negative result would not have known they reported a negative result. But because everybody tested the same sample, you can see that those laboratories have clearly made a mistake and failed to detect it. And when you drill down into the detail, you can see that the cause of the error was a primer design error where a SNP was under the primer binding site. And because these laboratories were all within a national consortium, they designed a common set of primers within the national consortium. They'd all used the same set of primers. They all got the same wrong result, in quotes, and would never have known unless they participated in EQA. So it emphasizes why it's important to do EQA. Everybody's getting the same sample. We've got 400 plus laboratories here. We can quite robustly detect systematic errors. As I alluded to earlier, we haven't detected any systematic errors this year, so there's nothing of concern that's flagged up to us. But if we did, and it was a commercial kit, for example, we'd go back to the manufacturer directly and report that error to them. I've got another question here which is great. So just pull it up 1 second. So do we offer EQA for testing of fusions in lung cancer? So for fusion gene testing, we have a pan-cancer scheme, which we're running in conjunction with IQM Path and a number of other EQA providers. We've done 1 round of that already. We've got another scheme coming up very shortly. So we've taken the decision to do pan-cancer testing rather than specific tumor types, primarily because it's so hard to find reference materials to do fusion genes, and because as a proportion of the total amount of testing that takes place, fusion gene testing is currently still relatively small compared to the more common biomarkers. So our approach, and that used by IQM Path, is to do a pan-cancer test, EQA for fusion genes, but we do include testing for relevant lung cancer variants in that. Please do look at the EMKN website if you want any more information, or email me directly, either through EMKN office@emkn.org or through my LinkedIn profile. Another question, what's the correct procedure for choosing a reference sequence when you're using commercial pipeline that uses human genome 19? So HG38, if I remember rightly. So the choice of reference sequence is really up to you as the end user, what reference you should do. I would strongly advocate that you use the main transcripts. So that's a stable reference. This transcript is defined by that, and for each different gene, and certainly for the genes of interest in this EQA, there should be a main transcript for all of those genes. So I would refer you to using a main transcript, and of course you can go to the EMKN website to download or contact the EMKN office to get our policy on mutation nomenclature, which again includes the summary of which reference sequence to use for which particular gene. Another one about systematic errors for different technologies. I think I've covered that, but the question here is amplicon versus capture NGS. An interesting one. We don't, as I alluded to before, we've not seen many systematic errors. Whilst we detect them, we don't detect them very often. This is very specifically targeted towards NGS. And that's the sort of question that's probably best addressed by our generic EQA scheme for next generation sequencing. We've got a somatic version there, and that does allow us to detect the differences in variant detection between amplicon-based and capture-based NGS strategies. So if you want some more details, do get in contact with me, but we're happy to point you in the direction of that EQA if necessary. And lastly, there's another question here about feedback of critical errors. So important to point out, so if we do detect laboratories, if we classify a laboratory as a poor performer, the process for that is that we provide you initially with a provisional individual laboratory report where we define whether you have got predicted poor performance or not. Every laboratory has an opportunity to appeal that decision. You have a 3-week window to appeal it. That appeal then gets reviewed by all the assessors, who, again, just like in the marking process, independently review your appeal and submit a response to us. And then that gets fed back to you when the final individual laboratory report is published. So the appeal response gets fed back on that. So I would encourage that that questionnaire, if they're not happy with the response, or they haven't found it, or they're not detected it, please do get in contact with the EMKN office, and I'm sure we can direct you to the right information to find the response to your appeal. Okay, this is an interesting one. So final question, I think we've got time for probably for this question. So this is really around molecular tumor boards. Now, this is obviously a development that's been evolving over the last couple of years, and not every country has a strategy that involves molecular tumor boards, but it's certainly much more common now than it was, say, 5 or 10 years ago. So when we look at the results, we are looking at the result the laboratory has reported for the clinical question we have asked in the referral question. So we're not taking into account we're not directly assessing the results as fed back by the molecular tumor board, but clearly, if that result has been through a review of an external body like a tumor board, and that's what the end user would report, then it would be covered. But this is not really what's covered in this EQA scheme, because we're capturing the data at the point of where the information is provided to the tumor board. So we're covering what the laboratory reports to the end user, the clinician, who would then sit on the tumor board. So no, it's not considered directly in the EMQN assessment process, because that doesn't reflect the pathway that we're covering in the EQA. There are initiatives going on within the wider pathology community, quality pathology community, particularly under the IQN Path initiative, to assess the quality of output from molecular tumor boards. And although I can't say in any great detail at the moment because it's still being developed and worked up on, I think you will start to see in the next 12 to 18 months the introduction of EQA that would cover the output of molecular tumor boards. So it's not covered in this EQA scheme, but it's something we are working on. Okay, I think that's all the questions we've got for today. So we're just about out of time. So I think I'm going to wrap it up just now. So a big thank you to all the participants, those you dialed in. If you're unable to dial in, of course, we will make this webinar available from the EMQN YouTube channel. Usually takes 2 or 3 weeks for us to get it through compliance, but we will notify all those who register for the webinar that that's available, and of course it will go out to the wider EMQN membership at the same time. So I thank you for your attendance. Any questions, you can contact me directly at office@emqn.org. Otherwise, I wish you a great afternoon and thank you for dialing in.